so.
And the problem is she's green in here, she's got her hopes, but that is not the same as knowing all the local people.
True.
It's a real trick.
Yeah. It's like
Are you
we're
here
all
for an
set.
interview?
Yeah, it looks like.
Blackford.
You know, we're all matching the grade top today.
Oh, there you
And
go.
this is
I
as
did
well.
get the email.
That's all part
You
of
guys
the
are going to do
coordination.
most of the talking. I'm just going to stand there. And
You can come over and hang with
The fellows are paying the airfare.
Have you guys had any trouble with playing slides off of the Google or not? Do I need to
Why
save
don't
them?
you just try?
Just go over them and make sure.
But then I'll give
The only issue I've seen before is like
That's okay.
things
I
moving
need,
around a little bit.
you've already given something away. Floppy
You didn't
baby is
have
very
to.
interesting.
Why don't you just try?
Just go over them and make sure.
Then I'll give
The only issue I've seen before is like
That's okay.
things moving around a little
You've
bit.
already given something away. Floppy
You
baby
didn't
is
have
very
to.
interesting. You know how to go to full screen?
Go over
I'm
them.
trying to figure out those.
It was not there's like things moving around a little
You've already given something away. Floppy baby is very interesting. You know how to go to full screen?
go over them. The only stuff before is like moving around a little
You've already given something away. Floppy baby is very interesting. Not looking.
And that was just like that.
Like, put
That
more
same
info.
color.
Okay.
That
Okay.
just would have been too
It
much.
seems to be working. Can we see all of it, or is it cutting off some of it?
No, it's perfect.
Okay, perfect.
It's just,
Ready to roll.
just looks very, the contrast looks very, vibrant.
David, can we see this? Okay, or is it?
They'll turn the lights off.
Okay. What am I signing?
Disclosure. Do you have anything to disclose? Do you have money hidden somewhere?
Yeah.
These companies?
Yeah.
That last company that makes that.
Genetics. Okay. Okay. Floppy baby is ready.
What's he on
This mic is picking up well.
I'll introduce you.
Hello?
Yes, it does. All right, guys, thank you so much for coming. Welcome to our complex case conference. We have a very interesting case. Our presenters are Dr. Killian, PUI2, Dr. Carvalho, PUI3, Dr. Ahmad from Peds Neurology, and Dr. Kumar from Peds Pulmonology. Thank you.
Hi guys, welcome. Thanks all for coming. Let me know if at any point you can't hear me. Just like give me a quick wave and then I'll adjust my volume. So the case that we're presenting today is a very interesting case of a flappy baby that showed up in our emergency room. So the baby showed up, a 12-week-old full-term infant, male infant, with sickle cell trait, who presented to emergency room with tachypnea and hypotonia. Mom was very concerned about worsening belly breathing also, and baby was pulling around his neck. She was also reporting some baseline weakness, weak cry, and she was very concerned about the shape of baby's head. She was saying it's a little flat on one side. But overall, she was saying the child is feeding well. He's occasionally gagging when he eats too much or too fast. In terms of other birth history for this infant, so this infant was born at an outside hospital, full term. His birth parameters are listed below, so pretty normal weight, pretty normal length as well, and head circumference. It was an uncomplicated birth and uncomplicated newborn nursery course. Of note, baby's urine tox screen was positive for benzodiazepines, but no other substances were detected. We know from the pediatrician that the newborn screen revealed sickle cell trait. Just a little bit more about mom and the pregnancy history. So mom is a G4P2032 woman. She herself has sickle cell disease with multiple complications with vaso-occlusive crises. Even during this pregnancy, she required multiple hospitalizations, about 6 to 8. She was on Dilaudid during pregnancy, and tramadol, also required some fentanyl use at some point. She was diagnosed with chlamydia, treated, and the treatment of cure was normal.
Was that early in the pregnancy, or?
This was not disclosed to us by the outside hospital. She also is using marijuana about once a week. She says that she sometimes uses it instead of Dilaudid for pain control for her sickle cell disease. But child overall, since birth, has been having adequate fluid intake and adequate urine output. In terms of past medical history, so summarizing what we know that this child has sickle cell trait identified on newborn screen. Baby also has some plagiocephaly, likely positional. This baby was circumcised without any complications, no other surgeries thus far, no known allergies, no medications, shots are up to date. So in terms of family history, the relevant components of this history are epilepsy in his half-brother, as well as some developmental delay and learning disabilities, also in the same half-brother. In terms of development goals for this child, he is able to track objects with eyes, but not moving his neck. He has a social smile, he's cooing, he has a significant head lag, and overall has limited movements, kind of lying around most of the day, moving his upper extremities slightly, but not moving his legs too much. On review of systems, so kind of as we addressed, baby is smiling, positional plagiocephaly. Mom is noting this fast breathing and using belly muscles to breathe, as well as some tugging at the neck. Again, muscle weakness and low tone. So on physical exam, child is afebrile, heart rate is normal at 149. The respiratory rate is at the upper level of normal, but child is sitting well, 99% on room air. When we look at the baby's weight, we notice, I know it's kind of hard to see here, but the first dot is right here, which is, I'll tell you exactly what percentage they're at. They're at 41st percentile at birth for weight. On presentation to UIC, they're noted to be at third percentile. In terms of the height, we believe that this is an erroneous measurement, so not very significant changes in length. And also we know that sometimes length is not a very accurate measurement because it depends on how we measure. But this head circumference is tracking nicely. So the baby was born at 77th percentile for head circumference, and at presentation was noted to be at 84 percentile. So physical exam, child does in fact have positional plagiocephaly, as mom was worried about. Other notable things are preauricular pit, tachypnea, subcostal retractions, but no flaring or grunting, no stridor or wheezes, no crackles. Heart exam, regular rate and rhythm, pretty unremarkable heart exam, no murmurs, allowed S1, S2. The cap refill is 3 seconds, but there was no brachiofemoral delay, no edema. On the initial exam, the abdominal exam was unremarkable. Extremities, in terms of extremities, baby is noted to be moving mostly upper extremities, but still not very active. And on the skin exam, we note that there are few hyperpigmented lesions. For the neurologic exam, so baby has significantly decreased tone throughout. There is a notable head lag, a weak cry, fair suck, weak grasp, absent Moro reflex, no detectable deep tendon reflexes, and it's difficult to elicit Babinski reflexes. So on the initial labs, we did a basic workup, starting with a basic metabolic profile, which was mostly unremarkable. The liver enzymes were also unremarkable, except for mild elevation of ammonia. Here, the upper limit of normal is 56, so anything 55 and below is normal. The CBC is pretty unremarkable as well. And manual diff is notable for some lymphocytosis. Additional labs that were done initially were lactic acid, which was normal. CK was elevated at 255. LD was normal. UA was normal, and the respiratory panel was positive for rhinoenterovirus, which likely explains that lymphocytosis. So as in any infant presenting initially with hypotonia, we want to make sure that we're ruling out child abuse. So skeletal survey was done, starting with the chest x-ray. It's not a great quality image because of the significant rotational component of the baby, but the chest x-ray in general looks normal as well. There is no signs of broken bones. So skull exam also unremarkable, extremities normal. We note some abdominal distension, a lot of gas in the bowels, but otherwise unremarkable as well. Okay. So decision was made to admit this baby to the hospital, and the child went to the general pediatrics floor. And I'll have Priscilla discuss the differential diagnosis that was considered.
All right. So where we are this far, so just a quick summary of our patient. So he's a 12-week-old male with worsening hypotonia, plagiocephaly, tachypnea, increased work of breathing, and these occasional gagging with feeds that mom kind of like brushes it off, but to us may become significant. So first, as we go through the differential, I'm going to approach it a little bit differently, and I want to distinguish between weakness versus hypotonia, which sometimes in the infant is hard to tell apart. So hypotonia or tone, when we're evaluating tone, we wanna see the infant or the patient's resistance to passive movement. So when you're examining the upper extremities or the lower extremities, and we know when they have low tone, they will have this a reduced resistance to these movements. They'll also not be able to sustain postural control and movement against gravity, which in this case, this patient pretty significantly meet those criteria. And then when we're evaluating for strength, so strength is the force that the patient can exert. So in weakness, you would have this diminished muscle power. Something of note that as we go through the differential, trying to distinguish central versus peripheral hypotonia, is that weak infants are always hypotonic, versus when they can be hypotonic and not necessarily weak at the same time. So these are just some of the exam maneuvers that we do when we're evaluating for tone in babies. Our infant had all of these present, so we note here the significant, head lag. When we're doing the horizontal hold, you see the inverted U shape, like this baby here. And then looking at the vertical suspension, so you want to grasp the infant at the, in the armpits here. This is a normal infant. This is what they should do. They should resist. They should have some strength in their upper body, versus completely slipping through your hands while you're holding them vertically. And then you also notice when we're doing this exam, the position of the legs. So it's, when distinguishing between central and peripheral, you can always notice the scissoring of the lower extremities, which our patient did not. This is not our patient. This is just an older child having that positive, the very hypotonic and that vertical suspension test as well. So when we're trying to distinguish between the two, central versus peripheral, there are 4 components that we're gonna focus through this differential. So you want to pay attention to the reflexes, so getting a very good neuro exam on your patient. The overall mental status and the level of consciousness, and kind of visual tracking going along a little bit with the mental status. You want to evaluate the infants if they are tracking, and overall muscle fasciculations, be tongue or anywhere in the body. So the reason those 4 points was brought up is that they will really help you distinguish between central and peripheral hypotonia. So in central hypotonia, they have a overall decreased level of consciousness. They do not track. Infants will fail to imitate facial gestures. They have a predominantly axial weakness versus peripheral weakness. They can have normal strength and be hypotonic, like we're distinguishing between the two, and their reflexes tend to be normal to hyperactive. Versus peripheral, they are generally alert. They have a normal, they can have a normal sleep-awake cycle. They respond to, to people, to the surroundings. They typically have profound weakness. Reflexes can be hypo or areflexic. They tend to have feeding difficulties, muscle fasciculations, and intention tremor as well. All right, so overall, we know that central is more common. So about 60 to 80% of hypotonia is central, from a central etiology, versus peripheral, it's about 15 to 30%. Central hypotonia tends to be, they can be acute or chronic, and you think overall as a centrally, so a brain insult, so a brain function that's not working properly. So central hypotonia you see in HIE, any encephalopathy or brain insult. You also tend to, so when differentiating between the two, you want to look at your patients to see if there's any any facial expression that's different. So because chromosomal and congenital disorders like Prader-Willi, trisomy 21, and Fragile X are more common to have central versus peripheral hypotonia. And also along with inborn error of metabolism and any neurometabolic disease. Peripheral, on the other hand, we try to kind of break it down into 4 different components of the peripheral nervous system. So you can have defects in your anterior horn cells, which you would see with patients with SMA. Peripheral nerve, you see with congenital hypomyelinating neuropathy and Dejerine-Sota's disease. And they can have effect in the neuromuscular junction, as you see with infantile botulism and myasthenia gravis, and also in the muscles, which you see with congenital myotonic dystrophy. So this is just, again, just to remind us, kind of going through that differential a little bit more. So central nervous system, your any chromosomal disorder, metabolic diseases, spinal cord injuries, cerebral dysgenesis, and HIE. You have your motor neuron, like SMA, so you'd see that in the anterior horn cells. In the nerve itself, with any hypomyelinating neuropathy. And I know those other 2 I mentioned, I won't go too much into detail with those. In the neuromuscular junction, so with any myasthenia gravis, the congenital or the transient kind, and infantile botulism also in that area. And then finally in the muscle, you have your dystrophies, your myopathies, or any other congenital myopathy disorder. So, reflecting back on our patient, we know, so we have pretty much this table is broken apart. So these are the central more injuries and symptoms, and this is the peripheral kind. So when we look at strength, we know that our patient is weak. So we can eliminate these 2. We know that the deep tender reflexes, we were not able to elicit them, so they're absent. The Babinski sign was absent in our patient, but that can be either central or peripheral in this case. The reflexes were absent, so we can eliminate the central injury. Now, muscle fasciculations, muscle mass, and sensation. At this point, we don't know by the initial physical exam that we have. Agnes will give us an update, and that will after we discuss with some of our consultants during the case, they became more apparent. So we'll skip that part for now. And then tone, we know that our patient had very decreased tone. So just from overall, we can eliminate basically the central. So we're going to focus on the peripheral hypotonia. So these are some of the cases that we'll briefly discuss. Also, just to not forget, there are other possible causes. So you do have some metabolic and multi-system diseases. Pompe disease was actually very much in our differential, and especially as the case evolves, you see why we were also considering Pompe. The primary carnitine deficiency, mostly related to central hypotonia, and you also have the neonatal adrenal leukodystrophy, which I won't focus too much on right now. So let's go on to our peripheral hypotonia neuropathies. So SMA, it's a degeneration of the anterior horn cells in the spinal cord and the motor nuclei of the brainstem. They can present from birth to adult life depending on the type. If we consider for our patient, he's roughly 3 months old, so it would be the Hartnett-Hoffman syndrome that's usually present between birth to 6 months of life. We know this is an autosomal recessive. You have usually this typical history of decreased fetal movement and breech position. And the symptoms can rapidly progress. The hypotonia, the weakness, reflex. You can see fasciculations in the tongue and in muscles. And then eventually they can have severe respiratory compromise and also swallowing difficulties. Of note, these infants are usually very alert. So they are, as with peripheral hypotonia, they are aware, they are smiling, they can track, which is kind of similar with what our patients so far. So we'll keep this one in our differential for now. The studies typically is confirmed with the SMN1 gene mutation for the type 1. The CK can be normally to mildly elevated, and if you were to do an EMG, you would see fibrillation and muscle denervation. Going through our peripheral hypotonia, we see also in the peripheral nerve, you see some of congenital hypomyelinating neuropathy. This is one of the Charcot-Marie-Tooth type. I didn't realize there were so many different types, but they are. This is the type 4E. So this is typically present at birth. So these neonates will have respiratory difficulty, muscle weakness, hypotonia. They will also be areflexed. So a lot of those, and the fasciculations as well. Usually, so with any demyelinating disease, just a quick reminder, we have your myelin sheaths in your nerves. So if these are destroyed, then you would have a decrease. The action potential will slow down in the nerve conduction, which can lead to hypotonia. Another one that's a little bit similar, it's another one of the Charcot-Marie-Tooth types. This is type 3. This is also the demyelinating peripheral neuropathy. That this one is more, it can present from infancy to later on. The symptoms, again, very similar to the previous one. And again, with the EMG, you would see a decrease in the nerve conduction that's severely decreased as well. So this one, if we were to choose, I would keep the congenital hypomyelinating neuropathy more than the Duchenne sotus, but it's also something that's possible in our case for this kid. So going through the neuromuscular junction, so the infantile botulism, right? So this is a presynaptic condition. So you have your synapses here. So the block of the acetylcholine release gets blocked, and it's by the Clostridium botulinum, which can be found in honey or also spores. It's very common. Typically, you will get a history of having a prodromal syndrome symptoms with constipation, poor feeding, and lethargy. They can have cranial nerve abnormalities. They can develop into cranial nerve abnormalities, hypotonia. They also have hyporeflexic and respiratory difficulties. So with infantile botulism, it is self-limited. It can last for 2 to 6 weeks. We think in this case, less likely, given the history that mom is giving. It's something that I would still consider, but less likely in our patient. And then we come through the myasthenia gravis. So with botulism, it's a presynaptic. Myasthenia gravis is a postsynaptic. So the acetylcholine is actually released, but the receptors are blocked by the antibodies. So we see there are two kinds. There's the transient and the congenital. In the transient kind, you get a history from mom actually having myasthenia gravis, and those symptoms will present more in the neonatal period because it's those antibodies from mom that's crossing the placenta and affecting the baby. With congenital myasthenia gravis, it's present early in the infancy, and you see some of the two symptoms that's not present in the transient is the ptosis and the ophthalmoplegia that's seen more in the congenital kind versus the transient kind. And these patients have severe respiratory failure that will eventually, at birth, they require some ventilation, so again, present in the neonatal period, and they can have also persistent episodes of apnea during the newborn course and weakness as well. Less likely than for this patient since we're out of that neonatal period, we're in the infancy period at this time. And then one last one, actually not last one quite, but we have the myotonic dystrophy. So this I thought was interesting, just a quick review, might not, because our patient really didn't have any dysmorphic features on exam, but with this you will see it can involve multiple systems, eyes, heart, endocrine system, and the CNS. You see these typical facies with the tenting of the upper lip, as you see in the progression in these pictures. Thin cheeks, wasting of the temporalis muscle. The history for these patients, you also, the birth history, you see polyhydramnios, prolonged labor, and they can lead to mechanical assistance, so respiratory problems. And then last, I just wanted to discuss Pompe disease. So this is one, it's a glycogen storage disease. So you have this genetic mutation in the GA trinucleotide. So this affects the acid maltase enzyme, which is responsible for the breakdown of glycogen. So if you can't break down glycogen, it just accumulates, and it will accumulate in different organs. There's typically 3 different types. You can have the classic infantile onset, non-classic infantile, which is usually present, diagnosed by 1 year of age, and the late onset. It is associated with cardiomyopathy and hepatosplenomegaly because, again, of all the glycogen that's going to different organs. And usually the diagnosis is a muscle biopsy where you see the vascular myopathy in these. This, initially, we kept this very much in our differential, as when Agnes presents some of the symptoms, this was still part of our top differential. So again, just a quick picture, so just remind you of where that glycogen can accumulate and lead to symptoms. All right, so this is sort of like how we land from our most likely to least likely at this point. Given all the symptoms, we strongly were considering SMA, in this case type 1. Glycogen storage disease, as his symptoms progressed during his course of hospitalization, also became something that we're highly considering. Also keeping in mind that any hypomyelinating disorder, and then less likely congenital myasthenia gravis, the infantile botulism, and metabolic disorders at this time, given the peripheral nature, less likely.
So just to briefly review, so we have a 12-week-old infant with hypotonia, mostly areflexic, with poor suck, no moro that we're able to elicit, and that exam was done by multiple providers. Baby feeding well, but mom is reporting some history of gagging. And we have noted a decrease in birth weight, in weight percentiles from birth to like roughly 40s to about 3% right now. So that's our history. So after the patient was admitted, and even just prior to the admissions, we consulted multiple services. One of them was neurology for evaluation of hypotonia. So on a thorough neurologic exam, we noted that there are intermittent tongue fasciculations, confirmed that there are, in fact, no deep tendon reflexes. Babinski was downgoing, which we all know at this age, that's abnormal finding because up to about 1 year of age, we would expect Babinski to be upgoing. There's very weak plantar and palmar grasp, and at this point, given these physical exam findings, there was a very strong concern for SMA. We also consulted the genetics service, who completed a very thorough evaluation of family history. So there's no family history of genetic, neurologic, or metabolic disorders in this family. They also recommended some additional testing. So we ended up sending carnitine panel, very long chain fatty acids, plasma amino acids, urine amino acids, and urine organic acids. These tests take a little longer to return, so the results were not readily available. Additionally, we consulted speech for evaluation of the swallow, given the history of these gagging episodes. So they did, in fact, note that there is signs of aspiration with standard flow nipple in cradled position, but not in elevated side-lying position. So this was a recommendation for them, is to then keep the infant in elevated side-lying position for all the feeds. Additionally, some of the providers noted that there was hepatosplenomegaly, so we ordered additional studies. One of them was ultrasound of the abdomen, which ruled out hepatomegaly. They thought the liver was actually a normal size. So that kind of leads us also away from Pompei's disease, where we would see a hepatomegaly. We also obtained EKG at this point. Given concern for Pompe, there would be an expected prolongation of the PR interval. However, the EKG was also normal. We also, to be thorough, evaluated the child with an echo, which turned out to be also normal. There was a tiny PFO, which for that age is not unusual. So some of the additional labs that were drawn started coming back. One of them was hemoglobin fractionation, given the history of known sickle cell trait identified on the newborn screen. So this was consistent with the sickle cell trait. However, knowing that there is expected elevated fetal hemoglobin at this age, we knew that this test would have to be eventually repeated. The lipid profile was normal. Uric acid was normal as well, slightly low, but not very remarkable. We evaluated pyruvate, that was also found to be normal, as well as lactate, which was also normal. We repeated the ammonia level because the initial one was 83, so mildly elevated. We noted that it was downtrending, and moved on. So on day of life 3, we consulted nutrition for poor weight gain. Child also started to desaturate to 91% on room air. We noted grunting that was unrelated to the feeds and started the child on half a liter via nasal cannula. We also started measuring end-tidal CO2 values, which this was done a little later, but mostly ranged between 40 to 45 with a peak of 50, and that improved with repositioning of the patient. So with these desaturations, we decided to obtain a repeat chest x-ray, which just showed some mild cardiomegaly, but no other changes, significant changes. At this point, we consulted pulmonology for increased work of breathing and desaturations. The recommendation was to start albuterol and aggressive chest physical therapy multiple times a day for airway clearance. They also recommended to keep the child NPO because the child is at high risk of aspiration. So the feeds were started via orogastric tube only. Okay, we also started an H2 blocker to limit reflux in this child, so this was famotidine. Okay, and at that point, baby was transferred to the PICU for close cardiopulmonary monitoring. Okay. So we have to be cautious with just using supplemental O2 because we know that it can decrease respiratory drive. So this we just have to be careful with using only O2 in infants presenting in this way with hypotonia. So BiPAP was definitely the preferred method for respiratory support. We had some trouble with the sizing of the mask at our institution, which is partially the reason why this child later ended up being transferred to another institution. So we obtained blood gases. So the initial blood gas was notable for very mild acidosis. The CO2 was elevated and the bicarb was elevated as well. This was thought to be due to compensated respiratory acidosis. The blood gases were trended over time with some notable improvement. However, the respiratory rate continued to fluctuate and was mostly hanging out towards the upper level of normal for this baby, so it's 60. And we started making plans for transfer of care due to possible impending respiratory compromise that could develop in an infant like this. So we ended up escalating care and transferring to Lurie Children's Hospital. The reason why the child was transferred to that particular institution is in addition to the respiratory support that might be required, this child, there's also a center specific for this disease at that place where the child will probably receive optimal care. So the child gets transferred, and days later, we start getting some updates from the lab. So some of the genetic testings start coming back. The carnitine panel is normal. The very long chain fatty acid profile is normal as well. Plasma amino acid, normal. Urine amino acid, same, normal. Same for urine organic acids, and microarray reveals a normal male. Now, 21 days later, we get a phone call from AROP with more news, and the genetic testing, one of the genetic tests that we sent came back positive for spinal muscular atrophy. There were 0 copies of the SMN1 on exon 7, which was consistent with a diagnosis of spinal muscular atrophy. So now Dr. Kumar will discuss the pulmonary considerations in a hypotonic infant.
Okay, so we all know it's spinal muscular atrophy, and you probably guessed it's type 1. So there's no conflict here. And so what is SMA? So it's a neuromuscular disease of infancy, childhood, and adulthood. And we do know that this is type 1, but we thought that I'll just cover type 2, 3, and 4 a little bit, so you'll get the whole spectrum. And also the pulmonary management varies depending on which type of SMA they are, and sometimes also depending on how they progress, it's the same pulmonary management we use. And it's characterized by progressive, predominantly proximal and symmetric muscle weakness. And this is important to know that sensation and cognition are preserved. As it was mentioned earlier, their intelligence is normal, and some studies show that they're even above normal, and their verbal IQ is actually much higher than the normal population. And so SMA is caused by the mutation in the SMN1 gene, and this is some numbers. So it's approximately affects 1 in 10,000 babies, but about 1 in every 50 American population is a genetic carrier and can affect any race or gender. And there are 4 types, 1, 2, 3, and 4, based on age of onset and highest physical milestone achieved. And these are the phenotypic variants. And you can see that based on the age of onset and what's the highest function they achieved, you can categorize them into type 1, 2, 3, and 4. SMA type 1 is characterized by profound hypotonia, absent reflexes as mentioned before, muscle fasciculations and tongue fasciculations, and also intercostal weakness, but it's important to remember that the diaphragm is spared, and they have this classic bell-shaped chest. So you see that in this picture actually, that's the bell-shaped chest. And they also have paradoxical breathing because of the weak intercostal muscles, and diaphragm is the only muscle which is helping them. And this is like, they call this as the Christmas tree pattern, where there is like crowding of the ribs because of the intercostal weakness. And SMA type 2, they have delayed motor milestones, inability to maintain independent sittings. Earlier, we used to call them as sitters and non-sitters. So non-sitters are type 1 and sitters are type 2. And lower extremities affected more than upper. Swallowing difficulty is common in most of these patients. Decreased cough and tracheal clearance, and kyphoscoliosis is another issue. So medical management, we'll talk a little bit more, but I just want to say that for pulmonary management, it's not just if it's SMA or Duchenne's or Becker's. Most of these neuromuscular diseases, when it comes to pulmonary management, they all fall under one kind of disorders where the management is pretty similar. So you can apply this to any patient who has weakness or hypotonia. And so management-wise, we have medical management, which is to improve health, and functional management is where you can improve their function, independence, and quality of life. So the different areas are, one is in the developmental area, GI, gastroenterology, orthopedic and musculoskeletal, craniofacial, pulmonary, mobility, and we'll also discuss briefly about functional disabilities. Developmental intelligence is normal. Gross motor milestones, SMA type 1, no significant milestone achieved. 2 and 3, it's important to remember that they may lose mobility as they grow, and it's much more common in Duchenne's muscular dystrophy. So we have these patients who come initially running into our clinic, they're able to play, and over the years they have falls, and finally they're wheelchair dependent and kind of proceeds to the same area where it's close to SMA1. And fine motor skills is variable depending on the type of SMA, and failure to thrive was a predominant character in this patient. So it's also important to note dysphagia is common in these patients, maybe not type 1, but type 2 and 3. When you see older children, they have chewing difficulties, and they get very tired even just by eating. And they also have very high, there's correlation with reflux. So it was true with this patient as well. So they usually are on beta blockers or proton pump inhibitors. Scoliosis is common, not in type 1 because their average lifespan is just 2 years, but type 2 and type 3, we see that these children have early onset scoliosis, like within the 4 to 9 years. Bracing is commonly done. It just slows progression, but it won't really stop. And also it decreases the FRC of the lung, but still the right thing to do is to brace. And they also have restrictive lung disease secondary to the worsening of scoliosis. And surgical correction slows rate of respiratory deterioration. And it's important to note that in patients with scoliosis, many times they believe that once the surgery is done, they regain their lung function, and that's not true. So what scoliosis does is it helps you to maintain the lung function which you currently have. What is lost is usually lost. So that's why it's important to, when you're talking to these parents, scoliosis surgeries will not help you regain the lost lung function most of the time. So this is just an image of scoliosis. So you do see some extreme scoliosis, and usually the surgical indication is that they're either symptomatic or the curve is greater than 50 degrees. So coming specifically to pulmonary and sleep, here the main issue here is that they have weak inspiratory and expiratory muscles and the hypotonia. So it affects airway clearance. So they're not able to mobilize their secretions, or they do not have an effective cough. And that leads to like inspissation of secretions, which leads to secondary infections. So they come quite often to the PICU. And they also are prone to aspiration disorder. So they have both kinds of aspiration, both antegrade and retrograde. So antegrade is where they have just very weak muscles. So what they eat directly can go to lung, and they also have severe reflux disease, so they can aspirate as well both ways. And usually these children progress to respiratory failure because of natural progression of the disease, and they also can have recurrent infections. They commonly have like nighttime desaturations and also hypoventilation. So this is important to remember, like most of our knee-jerk reaction when a patient walks into the ER, if their SATs are low, we put some oxygen on. But this is one particular group of population where actually you might be causing more harm than benefit, because the reason they're hypoxic is mainly secondary to hypoventilation because of their weak muscles. So their respiratory drive is not because of CO2, which is the normal respiratory drive. It's because of O2, which is hypoxic. They have a hypoxic respiratory drive. So the minute you put some oxygen on these patients through nasal cannula or the mask, it's just that you take away that hypoxic drive because they're not hypoxic anymore and they become apneic. And we have seen quite a few times in the ER where these kids get apneic and they get intubated for that. And once you intubate them, then they're breathing on their own. So something to remember, that oxygen is not always a good solution for patients with hypoventilation. So with shunt too, it doesn't help. So the only two mechanisms oxygen helps is if you have a diffusion defect or a VQ mismatch, like asthma, for example. So think about what the mechanism is when you see next time somebody is hypoxic or if somebody says the SATs are low. So this is kind of what all contributes to the respiratory failure. So we have gone through them, but I do believe aspiration, weakness, and recurrent infections are common. And also these patients have obstructive sleep apnea because of the hypotonia itself. And also oxygen is not the answer for that. And most of these kids, when these parents come to say us that they completely wet their entire pillows and they have to change the sheets because they sweat so much, that is because of the nighttime hypercarbia. And once you fix that with BiPAP, you see that their nighttime sweating improves. And many families are very happy that you could fix that small little problem, that they don't have to change the sheets every day and they feel like they sleep better. And airway clearance is important, and the order is very important. Not for all of these patients. First, we use albuterol because it opens up the airways and it also increases the ciliary beat rate. And then we do the West or the manual chest PT or high frequency oscillation device, which kind of, you guys have seen it. And all of these devices are the same. If somebody asks you which one is better, as long as you do it appropriately, all of them are equal. Manual, PT, West, acapella, PEP, all of them are the same as long as it's done the right way. And we also have cough assist for these patients because they're not able to cough well, so that's helpful. And suctioning and inhale steroids, and you need to follow this order because you don't want to give steroids first, then give albuterol, and then suction it all out. You want the steroids to stay in the lung. So non-invasive ventilation is common in these patients where we titrate the BiPAP. So that is the mini-me mask, which we didn't have at that time, but that was not the reason for transfer. The reason for transfer was because as it was a center, and also it's important, sometimes ENT, Peds ENT gets involved in these patients, and sooner or later, depending on the end of life discussions with the families, if they are going to go with the trach and vent, you need a center where they have a trach and vent clinic set up. So long time they either need, they may need tracheostomy and ventilator support. And functional disabilities, as we say, it's important to maximize their functional capacity and quality of life. So if you look at the skills, I mean, they're fully dependent on some of the skills, but when it comes to cognition, they're intact. And there are certain new technologies where there is adaptive modifications where they can eat by themselves and kind of help with their day-to-day activities. Mobility also, we are seeing more and more devices which helps them move from place to place. And there's also adaptive communication skills. So we don't see it as much as we would like to, but we do see quite a few of these patients start using it. So that might be the future. So no questions for now. I'll hand it over to Saba, and because I think we're running short on time, but I'll be here.
All right, so I'm going to give a little overview on spinal muscular atrophy and what it is and how it happens. So this is basically a neurodegenerative disorder affecting the anterior horn cells. It's characterized primarily by lower motor neuron signs, so weakness, muscle atrophy, fasciculations, particularly of the tongue, and reduced or absent DTRs. These four effectively are almost pathognomonic for spinal muscular atrophy, and our patient had all four of those things. It's an autosomal recessive disorder. It's commonly caused by mutations of the SMN1 gene. It's on chromosome 5q. There are other forms of SMA which are termed non-5q SMA. It affects anywhere from 1 in 6 to 10,000 live births, and about 60% of these patients are going to be the type 1 kind. So the vast majority of kids diagnosed with SMA have type 1 SMA. Harsha gave a nice overview of the different types, but basically the type 1s never sit. The type 2s sit independently at some point. Sometimes they lose their ability to sit over time. And then the type 3s are ambulatory, and type 4s are the most mild form, basically. So, SMN1 gene, what does it do? Truth is, we don't know 100% what it does. It's called a survival motor neuron 1 gene. It's found in the cellular nucleus as well as in the cytoplasm of all cells. In the nucleus, it's found in a subnuclear structure called the gemini of the coiled bodies, also known as GEMS. These structures are believed to play a role in messenger RNA processing. So the SMN protein forms a complex with the spliceosomal SNRPs or SNRNPs, and they're involved in SNRP biogenesis. And so basically what SMN does is it plays a key role in generating pre-messenger RNA splicing machinery, and it's involved in messenger RNA biogenesis. Now, it's present in all cells, so why does it target the anterior horn cells? And the answer to that is not quite understood at this point. It's hypothesized that there's some disrupted splicing of target genes or disrupted transport of messenger RNA to the distal axons in the lower motor neurons that leads to selective motor neuron dysfunction and death. But at this point, we really don't know exactly how it targets that. Now there's this other protein called SMN2. It's a nearly identical protein found near the centromere. It's part of an inverted duplication of chromosome 5q13. And there's a critical sequence difference where there's a C to T transition on exon 7, which results in a splicing error and removal of exon 7 from the final messenger RNA. So it kind of is an incomplete version of SMN1. So this causes a partially functional final protein that complexes with those the spliceosome machinery incompletely and results in impaired generation of that splice machinery. So this is just sort of a little cartoon of that. So over here you see the normal SMN1 form this normal protein, which can then splice appropriately. And then in SMN2, in the vast majority of the protein, we're missing that exon 7, so it forms this incomplete protein. Sometimes you get a kind of somebody who sneaks in through that, that wasn't spliced in the way that we expected, and so you can generate some amount of protein, but not nearly the same level as an SMN1. There is a pretty strong genotype-phenotype correlation. So disease severity seems directly related to the copy numbers of SMN2. And those copy numbers kind of correlate with the disease type. So absence of SMN2 in an SMN1 deficient patient is embryonically lethal. Our patient had 0 copies of SMN1, obviously, and then 2 copies of SMN2. So if you have 1 or 2 copies of SMN2, you're going to have one of the more severe phenotypes. In the less severe phenotypes, they have anywhere from 3 to 5 copies of SMN2. So that's sort of how you differentiate the two. Treatment historically has largely been supported. So there's the respiratory support with BiPAP or trach, good pulmonary toilet, nutritional support. Most of the time, these patients, all the time, these patients end up with a G-tube and sometimes with a Nissen. Seating and truncal support for stability and to reduce the effects of scoliosis. Surgery for restrictive lung disease, bracing, PT, walking assistive devices for the ambulatory patients. In the past, many disease-modifying therapies have been tried because this is actually, particularly the SMA1 is such a horribly devastating illness and does result in death most of the time by 2 years of life. People have tried valproic acid, phenylbutyrate, hydroxyurea, albuterol. These had all been shown to increase SMN transcription in vitro, but clinical trials didn't show any clinical improvement in disease progression, strength, or function. And then they also tried riluzole, gabapentin, olasoxime, which are supposedly neuroprotective, and again, no clinical benefit had been seen in patients in those trials. But recently, like a month and a half ago, a drug was approved by the FDA to treat children and adults with SMA. It's called nusinersen, and I had to practice that a lot to be able to say that. It's an intrathecal injection, and it basically is an antisense oligonucleotide. It's designed to alter the splicing of pre-messenger RNA and increase the production of the full-length SMN protein. So this was approved based on a phase 2 trial and a few phase 3 trials that were actually just in the middle of trial when they decided to approve. Our patient actually got transferred to Lurie because they were a study center, and he was going to be enrolled in this trial. So the phase 2 open label trial, it was a dose escalation study. It looked at 20 participants with type 1 SMA and compared these patients to the natural history of what they expected patients to do. So in the higher dose group, there were incremental improvements in motor milestones, motor function scores assessed by a validated rating scale, improved compound muscle action potentials, potential amplitudes in both ulnar and perineal nerves. This is assessed by nerve conduction studies. The median age of death or permanent ventilation, those are sort of those primary endpoints, was actually not reached during the study period, and the Kaplan-Meier survival curve diverged significantly in the patients who received the nusinersen compared to the natural history studies. And so they went to a phase 3. Oops, sorry, no, not quite to phase 3. The phase 2 continued. They also, on autopsy, analyzed tissue from the patients exposed to the nusinersen and showed drug uptake into the motor neurons in the spinal cord, as well as other drug uptake in other cell types in the brainstem and other brain regions. So they found increased SMN2 messenger RNA, exon 7 inclusion, and increased full functional SMN protein in the spinal cord. Adverse events were pretty minimal. They included upper and lower respiratory infections as well as some constipations, but most of the time, most patients actually tolerated this very well. So then it went to phase 3. There are a couple of phase 3 trials that had been happening. So the INDEAR trial was a randomized double-blind sham procedure controlled study in type 1 SMA patients who showed improved motor milestones. And again, a smaller percentage of treated children died, and these were statistically significant. There was also the CHERISH trial that looked at patients with type 2 SMA in a very similar fashion. In children with type 2 SMA, the treated children had improvement in their motor functional scores by 4 points, whereas the untreated children had a decline in their motor functional scores by about 1.9 points. And so these were also statistically significant, and so it went for approval, and in December it was approved, and so we actually have something to do for these children now. And I got a notice yesterday saying it's approved by one of the insurance companies that we contract with, one of the HMOs. We just have to do a prior auth on it, so that's just a nice, happy. It's every several weeks. I don't remember the exact frequency that they were giving it with, but I can find that for you.
Saba, this is awesome. I remember like my first year as a faculty member having a kid who I similarly found with SMA in my clinic. It was quite traumatic for me, and I can only imagine how traumatic it was for the parents, because I think, as everybody rightly said, those kids are extremely alert and awake and looking all over and seem to almost track with their bodies.
Yep.
Do you have a sense of how this child did?
So he was transferred specifically to be enrolled in the trial. After the medication got approved, I think he was probably part of the trial for 2 months. My hope is that he's getting the drug now, although I reached out to them last week and I haven't heard back from the physician that I sent them to. So my hope is he's doing okay.
I spoke to them like right before they got transferred home, because I was part of the when he was in the hospital, and Mom said at that time he was being fed like going home with feeds, and at that time it was right at the end of the hospitalization. I believe it was a month.
In October, yeah, he got like a G-tube, and then he was going to be.
Yeah, G-tube.
Yeah, he got a G-tube. Yeah.